everybody. Good afternoon. Thank you to the National Center for Healthcare Leadership for the invitation and all the work you did to bring me, as well as everyone else, here today. I'm very delighted to be with you all and honored that you've included me in your agenda. When you see a topic like the future of work and health, it seems to me that there is almost a natural starting point where a lot of these conversations go. And by that I mean here. Here's the Bureau of Labor Statistics. And I don't mean that we physically move ourselves to Washington, D.C. and go into BLS's offices, but many of us hinge our conversations around the future of work and health on one of their core outputs, the Occupational Outlook Handbook that they publish every other year. And they've been doing that since 1948. Interestingly, it was originally a consumer-directed deliverable, if you will, in the sense that it was to help Americans plan their careers after the war. And as many of you know, health has been the primary industry where we have projected high demand for new jobs year after year after year. Essentially for the last decade, healthcare and social assistance have been the top industry for new job growth, according to the BLS. For point of reference, for the next 10 years, the expected new job growth in healthcare alone is to grow by 14%, higher than any other industry, higher than the average of all the industries taken together. And as many of you know, you can really sum up a lot of where that new growth is going to come up by two positions: home health care aides and personal care aides. Of the 2 million new jobs we're expecting in healthcare and social assistance services, about 1 million of them are going to be in this home health and social assistance personal care aid. There's also demand for occupational therapy assistants, physician assistants, nurse practitioners, and speech-language pathologists. Okay, nobody's surprised here, right? This is exactly what you can anticipate if you're paying attention to the demographic trends of this country and if you're paying attention to the epidemiological realities of this country, right? We've got an aging boom coming our way, and we've got a chronic disease burden issue that's going to demand a lot of care that happens both inside and outside of clinical settings. So I start here because I think a lot of times this is where the conversation around the future of work and health ends, at least the strategic kind of conversation. From here on out, leaders get so overwhelmed by that level of demand. They say, how am I have so many openings in this position today, and you're telling me I'm going to need to continue to meet that level of demand for year after year after year to come. It gets so overwhelming to so many leaders that it almost immediately becomes much more a conversation about operations. You forget the strategy part. You forget what the initial start of the conversation was to envision the future of work and health, and you get sort of down to business to figure out, how am I going to fill these positions? How am I going to run a health system that needs that has that many openings? But what I'd like to submit to you today, and for this hour that we spend together having this conversation, and there will be time where you'll be with your table mates sorting through all this, is that if you go back to that original topic, you realize that the future of work and health is about so much more than meeting what is essentially just projected demand. And I think for you all in this room, what I'd like you to consider as leaders in healthcare is that the future of work and health is really about the supply side. It's really about thinking about quality work in healthcare, not meeting the demand of a job as it exists today, but reimagining what healthcare work looks like over the next decade, given a number of forces that will shape it. And in order for you and me to have a conversation about quality work in healthcare at all levels and all job classifications, we're going to have to address a couple elephants in the room. And the first elephant in the room is what we also all know. Home healthcare work is hard, really hard, and it pays very poorly. So if we go back to BLS data, we're reminded that the average pay for a personal care or home health aide is about $22,600 annually. You think about the 800,000 job openings that we're going to try to fill in the next decade to do this kind of work. We're talking about 800,000 families trying to survive on $22,600 a year. And they're not alone, right? We've got lots of industries, unfortunately, and lots of job classifications that pay rather poorly. Janitors and cleaners, food prep and servers, data entry, medical assistants, and if you have a millennial at your table, you might have to explain what a switchboard operator is, but apparently they don't earn very much either. All of these jobs pay what the Economic Policy Institute refers to as poverty wages, which essentially says even if those people are fully employed, working full-time all year long, depending on their family structure, depending on the makeup of the family, depending on the metropolitan area in which they reside, many of them will never make it to meet the federal poverty guideline of our country. And it's not a small number. It's not a non-trivial number of Americans that we're talking about are people who live in the United States. It's about 11% of our workforce. And most of them are families. Most of them are parents. So I bring this up because if there are people in the room that are sitting here thinking, look, I'm not in HR. I don't set prices. We've got a strong union. These are non-licensed job classifications. This is really out of my area of expertise or even sort of involvement. Then what I'd submit to you is even if you're not involved in the supply side of job creation, many of you, if not all of you, are caregivers. And you're all participating in taking care of the people that live in your community. And what we're learning is that people who are earning low wages for a significant amount of time have health risks that are directly associated with the fact that they are earning these poverty wages. And so as caregivers, as healthcare providers, there's also a reason to pay attention to low-wage work because there are health risks that we need to understand that are directly correlated to the fact that they're earning those low wages. So Paul Lee at UC Davis has done some really interesting work that he published in Preventative Medicine that essentially said, we need to think about minimum wage or low-wage work as occupational hazards, and we need to target low-wage work for disease prevention and health promotion efforts. So in other words, we need to think of low wage as a risk factor, and we need to start to think about how do we treat and care for people who are experiencing this risk factor. A sociologist named Matthew Desmond, who's at Princeton, has also been doing really interesting work on the impact of poverty wages or low wages on health. And his argument is he's saying, we need to think about this as the 21st century occupational health risk. That if we have this many people in our community that are earning low wages, and we need to think of it as if they're being exposed to a toxin, not unlike how we thought about toxins 100 years ago, when we thought about chemicals and cruel labor conditions. His argument is that because these toxins compromise the well-being of workers and their children. So here's my thought for you all. Oftentimes when we talk about quality jobs, we rely on a framework like this. This was developed by the Economic Policy Institute in the 1970s. And it argues that a quality job has salary. So we've talked a fair bit about how wage matters, and we need to think about what we pay people if we're interested in creating quality jobs. Maybe it has some pension, maybe it has some health insurance, a little bit of time off, perhaps has some professional development aspects to it, may even have some equity, some wealth generation bit in terms of stock or some other wealth-generating asset, and then maybe it has access to transportation. But the other point I'd encourage you to think about the next decade is that this definition of what is a quality job just might not hold up given the amount of social and demographic changes we've already experienced and will continue to experience over the next decade. So while it's true that most children live in homes with two parents, 50% 50.7 million of the children in this country presently live in a home that has two parents. 20 million do not. And so if you're creating a quality job for someone who's a single parent, you may need to be thinking about childcare and the role that childcare plays in whether or not that person can actually work full-time, or whether or not that person can work the schedule that's available to them. Similarly, we have a caregiving crisis in this country that you all know about. It's well documented, but we're about to experience it at a pace and a level we're not at all equipped for. So the first point, the number that most people say is that 41 million Americans are somehow involved in caregiving. And I mean the unpaid, the kind we often call informal. This is more recent data from the CDC, which was asking, during the past 30 days, did you provide regular care or assistance to a friend or family member who has a health problem or disability? And as you can see, on average, we're at about a quarter. But when you dive into that data, you can see that certain states are already experiencing a really acute challenge with caregiving, and it's critical for you all because 61% of caregivers work, and about half of them work full-time. So we need to start to think about what does a quality job look like in the future when you need to assume that somewhere between a quarter to a half of your workers, especially those 40 and above, are playing some sort of role in caregiving for a family or a friend. So it may just be that when you think about what a quality job looks like in 2030, you need to add in childcare and caregiving as a core component to what quality work looks like over the next decade. So with that, I'm going to ask you to turn to your table mates and just reflect on what you just heard and think about what over the next decade could healthcare do to address what we're now talking about as these health harms and vulnerabilities that are related to low quality jobs. I'll give you a few minutes to consider that and think through it with your table mates. Nice to meet you. I didn't catch your name.
Tahani.
Tahani. What a pretty name. Yeah. Are you here in Chicago?
Yes, I am.
Okay, good. Good. Thank you. About one more minute. Okay, you can start to wrap up your conversations. Any table get to the answer? I am curious, so anyone want to share something they heard, a surprising insight or observation somebody made? I think there's a mic coming to you. Just bear with them 1 second. They are sprinting.
Your steps in for today. So we were talking just about, are there some models that we might be able to replicate from other sort of vocations? And so we were thinking about, the nursing model where folks can work 12-hour shifts and then be able to do 3 or 4 days and then they can set their schedule around that. That would possibly help with individuals who find themselves dealing with these situations.
Yeah, yeah. Are there any systems that have a handle on how many people you employ that are presently serving as a family caregiver? Anyone doing audits? I know the tech industry just started doing them to get a sense of who on staff has other obligations. Any other comments before we move on? Okay, one more, and then we'll move on.
Hello, everyone. We spoke at our table about options for continuing education, either partnering with local universities or colleges, offering online education options, looking at tuition reimbursement policies, increasing tuition reimbursement, also offering childcare on site. For employees who are interested in going and pursuing further degrees. But I also wanted to make a comment on caregivers. So in our organization, we actually started a caregivers employee resource group, more so to provide support to those who have identified themselves as caregivers and just wanted a space or a forum to talk about what they've been going through as caregivers and also what resources we can offer them. And so one of the things that came out of that, for example, was a session on Alzheimer's and what that means and what it looks like to work with a family member who's addressing that. And so that's led to other conversations about what resources are available in our health system, tapping into employee assistance programs. So that has also, opened up a door as to how we can offer more support to our employees in that sense.
Really nice, thank you. Yeah, you're sort of well suited in many ways to serve as an information source as much as any other type of support. Okay, one more comment in the back, then we'll move on.
And one of the things that we discussed at the table is sometimes we need to shift our mindset, our kind of a mental model that the benefits that we need to think about is as a health system, we invest money in our community to address healthcare disparities. And we're not looking into how many health disparities have our own employees. Yeah. So we normally only look into, I want to save money or how much benefit costs on saving as a CHRO, for example. I've been there before. But it's like, are we willing to start looking at this in a systemic way and study social determinants and disparity within our employees? And maybe we may need to start thinking about helping them with housing or with transportation. We do that for the community to try to save money costs in the healthcare costs. So I think it's really completely shifting upside down the mindset of what benefits are.
There's a really nice comment. I was participating in a conversation about community health workers, but it was the same, that suggested if hospitals are going to get really excited about community health workers, but yet we're not going to pay them a living wage, aren't we just creating a job classification that will be full of all sorts of the health risks we're trying to avoid? So thank you. Okay, so back to our elephants. If the first elephant in the room might be that we have to address the supply side of the job openings that we're anticipating over the next decade, then the second elephant has to do with automation. So Everyone's fairly familiar, I imagine, with the narrative around automation. It generally starts with the truck drivers, right? Those poor truck drivers that are going to get replaced by autonomous trucks, and what are we going to do? Oh, I know, we'll repurpose them into nurses or whatever the newest occupation for the truck drivers is. And it's true that this is happening, right? This sort of transition of more long-haul truckers getting replaced by organizations like This Is Too Simple, which is a autonomous truck fleet from China, but they're operating in my state of Texas as well as Arizona. They aspire to have about 500 autonomous trucks operating in the United States by the end of 2020. So steadily making some progress in shifting logistics into an autonomous tech space rather than a human labor job. And then there's, of course, the world of supply chain and logistics. So here's I Am Robotics, which is a very cool startup out of Pittsburgh. For anybody from that region, Pittsburgh is a really interesting space to watch if you're interested in any kind of automation of your supply side or anything to do with logistics. And I'm sorry about the visual here, but essentially this robot that they're building is empowered with two really core technologies. So of course there's artificial intelligence, but there's also computer vision, which is very popular in the tech industry because what that allows is for that device to actually make decisions, as they say. So it can sort of scan what's available in front of it, and with its AI algorithms, it can sort of move independently around a factory space or a logistics warehouse and get what it needs from one place to another. Knowledge work is not immune to sort of the steady march of automation. This one upset all sorts of lawyers when JP Morgan published some research that said they've got an algorithm that they're now using, or at least piloting, for discovery work. And what they were able to show is that their algorithm could essentially do what took human lawyers 360,000 hours to do. The algorithm could essentially scan that same amount of discovery paperwork in a matter of seconds. And then, for the last few years, it's always been like, well, creative industries, they can't get that the AI will be saved by all becoming creative thinkers and artists and designers. But this is actually Promethean Ai. And how this works is you say to the AI, which also has voice-enabled computing, build me a bedroom from the 1980s. And in 3 seconds, this appears. And then you could say, add a desk, because that desk wasn't in the first visual. And then it puts the desk in. And what gets artists really excited is not only does it get the desk, but it adds the appropriate shadowing and coloring that would happen the minute you put the desk in. So for people who are developing games or for people who are developing content all the time, having some sort of AI that allows them to just get this kind of baseline up very quickly is an exciting, although threatening, development in AI meets sort of the creative space. And then you knew it was coming, right? So then there's healthcare and the complicated relationship that AI and the tech industry are having as they intersect with hospitals and the health system in general. So I'm guessing a number of you saw when Google published that they essentially argue that their algorithm is better than most hospitals' early warning scores around predicting mortality of patients as they've been admitted into the hospital. And so they published about a year ago and said, look, we were able to get access to electronic health records, and we went toe-to-toe with the early warning scores and systems that were in place in these health systems, and time again, our algorithm performed better. And what they said was they examined 175,000 people or patients that were admitted, about 214,000 patient interactions. And they said the biggest difference, though, is that for every single one of their the cumulative amount of data they looked at was 175,000 data points. And they said their big advancement in their AI is it has natural language processing. It can read handwritten, wait for it, physician writing. And that is why they think they've been able to make this leap to not only compete with this existing systems, but actually do better, because now it can, in their mind, they can handle all the different inputs they would need to need in order to make a quantifiably accurate prediction on mortality rates after an admission into the hospital. So, we're at this moment where for the last decade or so, there's been so much of this threat of automation that it's going to displace workers, it's going to take our jobs, and lots of people, luminaries, futurists, economists, everyone else is sort of has a point of view on just how many jobs, where they're going to be, where your job is safe, what your child should be studying, et cetera, et cetera. So MIT Technology Review actually last year tried to take all the different studies that have been produced over the last few years and to get a sense of where are we really in this automation story. And they came back after looking at work from Forrester and McKinsey and Gartner and lots of academic institutions, and their takeaway was, we have no idea. There's as many opinions about what automation will do to work as there are studies. And so it leaves us sort of in this interesting moment where we see AI, we see that it's getting stronger and more capable, we see very interesting experimentation happening across sectors, including sectors and industries we didn't think AI would touch, but we're not exactly sure what the impact will be. So if I bring us back to this conversation we're having about the future of work and health, what I would offer to you is that for you as leaders in the industry, it's not so much about how automation will displace workers or where those human job losses will be. It's about understanding and observing how it's already changing how we work. So let's unpack that just a little bit. What you're looking at here is a young boy from Syria, a young Syrian boy who's in a refugee camp in Lebanon. And the gentleman next to him is a tech entrepreneur who works for a startup called X2 AI. And what they've created is a talk therapy bot. It's called Karim. And what they're trying to do is offer behavioral health talk therapy solutions to the children in these refugee settlements who, according to their argument, have no access to any human therapist. So while it may not be a perfect solution, they're saying, look, we need to be able to provide some sort of support to these children who have experienced extreme trauma and also need talk therapy support. Karim is the little brother of their main product, which is called Tess. And Tess is something that they sell in this country and in Europe and has quite, so it's an interesting amount of pickup. And what's interesting here is they're no longer making this so much about access or sort of solving for the talk therapy desert so much as they're saying this is an affordable way, and this is a way that people who otherwise won't talk to humans might get some talk therapy. And so they're joining kind of this movement that's quickly catching steam that says, whoever said that talking to a human was the best way to get talk therapy? I've got like Andy right in front of me. I'm going to look at somebody else. So why have we ever tested whether or not we would actually all do better if we were to talk to a machine? So as you know, the military is very interested in this question, and USC is doing some interesting research with returning veterans to understand, would they do better if they talk to a virtual human, as they call it, or a virtual therapist. Her name is Ellie. And would we have access to different populations if we were to offer both machine therapists as well as carbon therapists as options? And so I think when you're thinking about how is automation changing work in this conversation, I think what's interesting to think about is how technology is changing our relationship with things. And so Professor Lucas at USC, her point of people are very open to feeling connected to things that aren't people. And that sounds sort of absurd at first, but think about your relationship with your phone right now and just extrapolate that into the future. I think that notion of people being very connected people are very open to connecting things to things that aren't people. It's interesting when you think about Mercy, their virtual care hospital, where, you know, for the last few years or so, they've been saying, we don't have patients here, we just have teams of health professionals who are observing and monitoring and taking care of people, patients that are distributed throughout the community. And they've created all sorts of new job categories that are really interesting to look at, but when you look at what one of the core competencies is for almost every single one of their new jobs, it's all about the monitoring and the tracking of data flowing from these homes, from the bodies of these people, back into, you know, their databases. I imagine that a lot of you are now on the chase to hire digital coaches, another one of these jobs that we're not exactly sure what the core qualifications are. I know some health systems think that customer relations is a better place, like hiring from Starbucks is a better place than trying to train someone up through the healthcare system to be good at digital coaching, which requires a lot of encouragement and people skills and you know, things that arguably come, you know, have been trained more easily in retail settings. And then we're all trying to figure out how to incorporate all sorts of wearables, ingestibles, and sort of home sensors into our understanding of patients moving forward. But I think the takeaway is whether or not you're going Mercy's route and you're going to have a virtual hospital by 2030, we have to remember that people have these new relationships with their things. And so when you're caring for a human, you're also going to sort of have to take into consideration all the technology that they're using to support their health and their well-being. Same thing goes as we start to watch smart pills enter into the care continuum. So this is Proteus Digital Health. This is their smart pill that they, you know, are now using for about 7 patients in Minnesota who have cancer. It's a very, you know, my tech colleagues will tell me it's a very dumb pill in the sense that all it's able to do at this point is track at what time it went into the body. It has a sort of a wet sensor on it, so it can track when it went into the body. But at this point, it's sort of an early signal that suggests, are we moving in a direction where more and more of the medications and the therapies that go into our body will be trackable, and increasingly will patients expect that anything that goes into their body is something they'll be able to get a readout on their iPad or in some other technology. Okay, so if we talked about sort of our relationship with things changing, then we also want to talk about how technology is changing just how we find work, right? In many ways, healthcare hasn't experienced the gig economy the way that other industries already have, but it's increasingly coming. So about 2 years ago, the NHS in the UK announced that they were going to try out a gig economy app for nurses. And they had essentially identified 12 regions, I think they call them, where they were going to stop having full-time employment nurses and instead have an app. Their argument, of course, like everybody on the gig, sort of pro-gig side, is like, think about the convenience, to your point over here, think about the control that those nurses would have if they got to choose where they wanted to work and what time they wanted to work. That type of mentality is also coming to the US. So this is Trusted. This is a startup down in Houston that's part of the Medical Center Innovation down there. And they're trying to do the same thing in the US. They're sort of targeting millennial nurses who don't want to work full-time for one health system. They would like the freedom of being able to work for wherever they want. They want to move around a lot. They want to be able to get a job wherever they go. And they're trying to cut through some of the friction that it takes to get a job in all the different areas of the country they want to live in. Nurses are certainly an area where there's a lot of experimentation and sort of venture capital investment, but physicians aren't completely immune to this either. This is another millennial play called Nomad, which is sort of targeting today's physicians who, again, maybe don't want to work full-time for one healthcare organization, but are interested in being able to travel, be a nomad, and be able to pick up work wherever they might be. I think these really challenge a lot of health systems' strong foundational belief in fit. You all spend so much time sort of talking about your own culture and how you have a way of doing things and how people, it's the people that work here that make us who we are. All of that is likely true, but I do think if you're watching sort of the gig technology and sort of we call it the digital coordination space, you realize that our need for culture and fit may have to change or evolve as more kind of enabling technologies like these allow people seeking work to kind of come in and out of your organization as they prefer. And where the most effort is probably happening, where the most activity is happening, goes back again to our conversation about caregivers. So we're seeing lots of pickup and interesting startups that are kind of creating new job classifications and new ways of working when it comes to those caregivers. This is Honor. Some of you may have heard of Honor. It's in a few different cities now across the US. It started in San Francisco by a bunch of former Google employees who were, again, trying to figure out why it is they can't match make a caregiver who could help them with their elderly parent who maybe lives in a city not where they live. When they can match make everything else in their life, why can't they match make caregiving? So they've sort of tackled it pretty aggressively, and they are kind of trying to start a new path or carve a new path out that allows people who want to work as caregivers or home health aides to be able to find people who are in need of that service using their platform. So it's interesting to think about how this could be one way we chip away at all those openings and all that need for care in our communities. But there's also some warning signs, again, when we think about, are we moving toward quality jobs? Is using digital matchmaking technology like Honor going to help us achieve what we would like in terms of quality jobs? And one area that we at Institute for the Future are really interested in understanding is what it's like to work in an environment where you're rated all the time. So this is an Uber rating. And if you work for Uber, you get, sorry, you're an independent contractor, but if you independently contract for Uber, you get a rating summary from them every week that tells you how you did. And Uber drivers are now, there's interesting studies going on to understand the level of stress and anxiety that comes when you are constantly being rated and you have no boss, you report to a platform or an algorithm, and so it's very difficult to be able to explain a poor rating or protest one you don't agree with. Instacart has taken it kind of to a whole new level of rating where the pressure that's being put on people who are part of Instacart, so for those of you who don't know, Instacart is a personal shopping app, that if you don't take the jobs that they're giving, that they're presenting for you, your rating will go down. So now it sort of challenges what the original value proposition of gig work was, which was you have flexibility, you have control, you pick what's right for you. But if you don't take enough gigs from Instacart, that will affect your reputation. That affects your rating. So we're beginning to observe what it's like for workers in this new economy when they're being rated and monitored consistently. So for leaders, I'd say the future of work and health, again, is about that idea of are we building quality jobs? And then when it comes to this automation, it's about, are we helping create positive partnerships between humans and machines? We don't want to find ourselves in a situation where, as leaders, we're using those machines to monitor, track, and rate our employees if we think that will be at the expense of creating quality jobs. So if we go back to the model, again, the model that was created in the 70s, we might think, okay, we've added childcare and caregiving as a core component of what a quality job might look like. I think it also deserves an examination of what safe working conditions are. So when you think about psychologically safe work, when you're being rated and monitored and tracked all the time, is that psychologically safe space for people to work in? Similarly, if your health system is assuming fewer people in the hospital, more people getting care at home or in third space locations, what is the safety that you're thinking about around those caregivers, nurses, RNs, LPNs, whoever you have out in the community doing that care that you anticipate will not be in the hospital? What are their working conditions like? If it's their car, is that a safe working condition for them? If it's someone's home, is that psychologically or physically safe for them? And then this question of dignity or meaning comes up, right? As we kind of experience a decade where a number of us are going to feel like we're in a job that will be eventually automated, but right now the systems are just trying to learn what we do so they can replicate it. Think about those lawyers doing that discovery work at JP Morgan, knowing that the work you're doing is feeding the algorithm that will then eventually replace you. How do we ensure over this next decade that people still feel meaning from their work and dignity in doing it? And what are the other aspects of building quality work in 2030? We don't need to rely on a model that was made almost 45 years ago in order to understand quality work in the 21st century. So I'm going to turn you back to your tables one more time to reflect on this conversation around automation and to think about what it is that automation can do to support the cultivation of quality jobs and quality work in healthcare. about 1 more minute. Okay. Can we hear from some of the tables on some of the ideas that were generated around the role automation can play in producing quality work, quality jobs? It's funny, it went from being so loud. We've got one here.
Hi, our table talked about, for example, a nurse, and that if some of the survey part, not survey, the sign-in part for a patient and some of the questions could be automated, the more mundane tasks, it gives the nurses more time with their patient and more quality time with their patient, which would hopefully then subsequently improve patient care, improves employee engagement, and it allows them more time to be a better caregiver.
Yeah.
I had just talked about a recent article I saw about a robot in a nursing home, and I don't know if people saw that, but how effective the robot was in really connecting with the residents of the nursing home, and there was concern on the part of the caretakers, the caregivers in the nursing home, that they would lose their jobs.
Yeah.
But that didn't happen. It made the residents much more amenable to care. It eased the jobs of the caregivers, and everybody sort of became friends with the robot.
Yeah.
So it was a win-win, and they were really testing it, and people established a relationship with the robot, and as did the caregivers.
Yeah, that's such a nice example. I think because it's orientating around a partnership, right? Rather than if it comes in, my job is gone. Recognizing we have different strengths. It never needs a break. It can work 24 hours a day. I can find ways, as long as the conditions are right, for my job to actually improve with the addition of automated technology. So yeah, thank you. Obviously, Japan is a really interesting country to study if you're interested in what it looks like when you actually just don't have the labor and you need to get pretty aggressive with using caregiving robots in elderly communities. Other comments? There's one up here in front. Tim?
Well, I mentioned the fact that I had conversations recently, the last 6 months, I guess, with 2 physicians. And one of them was a radiologist, where I've heard it opined that AI can replace radiologists. And he was, no. It makes me so much more effective because I get thousands of slices in a CT scan, and there's no way humanly possible that I can look at all the slices. But I can use AI to help me focus on where I need to focus to make the diagnosis and to help. So he thought it was a real enabler in his job. And the other was an oncologist. For obvious reasons, he can't keep up with every change that's going on in research in cancer care. And by reading journals and being with colleagues and going to conferences, and he can use AI to help discern what's the next best pathway for this patient.
Right.
So those were 2 kind of examples of people, and they're both late careerists, but they both seem to be embracing AI as opposed to electronic health records, which is a whole other story.
Wait, just keep the mic for a sec. What do they think their role in that partnership, what do they give back to the machine, or what makes it a partnership? I understand what the machine's doing for them. What are they doing?
Ooh. I think they're giving context to the data that that AI brings. And so as something's looking through all these slices on a CT scan, there's going to be a lot of aberration in there.
Yeah.
So they bring context to that.
Yep.
That would be. I'm not sure they answered that. That's
Yeah, yeah. No, I think that's right. And deviation. I mean, I've heard actually clinicians talk about if everything becomes so rote and you depend on your AI to read all the scans and do everything, who deviates? Who comes up with a new way of doing things and then feeds that into the algorithm? Because otherwise the algorithm's just always going to give out the last thing we know is right, but who's going to be doing the innovation if we're not training our young clinicians to actually know how to go against the algorithm? One last comment maybe, and then we'll wrap up here.
Hi, I'm Judy Zola from Boston Children's. We have a product that we are piloting there called Huggable, which is, you may have seen it in some of the news reports, and it's a stuffed animal that has AI behind its quote-unquote eyes, and it interacts with children that are very nervous about coming to the hospital. And we use a video about Huggable in our new hire orientation. And what's really nice about the video is that the child care specialists are right in the video as well, and saying how they work directly with Huggable to make the child feel more comfortable.
That's great. Yeah, I have seen Huggable. Good. Well, I had asked Tim about what he thought the physicians brought back, because what I thought you were going to say, it was a leading question, is I thought you were going to say, well, they bring patient care and they can be compassionate because the machine's doing all the sort of intellectual analysis. They can then be the judgment and the transfer of that knowledge to the person sitting across from them. But what I think, and you'll certainly get into next with Dr. Schanefeld, but I think there's a real, maybe this is the final elephant in the room. I didn't phrase it like that when I was preparing my remarks, but we need to make sure that our healthcare professionals actually know how to provide compassionate care. Many of them have been having to do so much work for so long, and I know you're going to talk intensely about burnout, that part of what those soft skills are, that many advocate that that's what healthcare professionals will bring to the partnership, are going to need to have some attention to if we think that our physicians and our overworked healthcare providers are going to immediately switch into being able to provide this caring, compassionate communication that they have not been working on very comprehensively for the last few decades. So there's an interesting new 8-week program at Stanford that's actually about compassion cultivation training. And it's not just for healthcare. I mean, their point is really, we keep saying that what humans will bring to this conversation is the communication skills, but data keeps showing us that very few professionals actually have those communication skills anymore, and we haven't been teaching them in medical school, and we haven't been teaching them in business school. And so if we are to be good partners with our AI systems that are coming up with us, we're also going to have to think about how we actually teach compassion. And the good news is there are new programs and there are really smart people that are trying to figure out how you do it, because to be frank, we've really never done it. And so it's another area that we'll explore, I think, over the next decade as humans have to learn or relearn some of these soft skills that we just haven't valued very much in many industries. So my closing remarks here are actually, as a futurist, I'm going to take you way back to about 100 years ago. This is the World's Fair in 1939 in New York. And back then, GM, General Motors, had created Futurama 1. Some of you might remember 2. This was 1, where they offered, you've sat around it, and they offered you a view into the future. So you kind of looked in and you could see all the things that GM envisioned for the future. It was so popular that they did it again in 1964. This was Tomorrowland. And again, in this case, instead of sitting there, you actually went on like a ride, as though it were like a amusement park ride. And they showed you things like people living on, living under the ocean, people living in other planets, and they really inspired you to envision what a 50-year and then a 100-year future could look like. And when you finished Futurama, you were given a pin, well, it was a lapel, and then it became a badge that says, "I have seen the future, General Motors." And IFTF, my organization, was founded in the 60s, and it was founded really to reject that idea that large corporations or large governments own the future, and that we are sort of passive recipients of the future that they offer. And so we actually have hacked their badge, and we encourage everyone we sort of interact with to not allow other people to go ahead and build and define your future. That our job as leaders is really to make the future. There's clearly a lot of work you can do to just acknowledge the challenges and address the immediate problems, but to put into some of your job description, what am I doing to make the future that I want? Because I'll end with the Buckminster Fuller, who says, "We are called to be architects of the future and not its victims." So my last and final words for you all will be that I hope you actively pursue the future as an architect and not a passive victim of what is to come. So with that, I thank you all for your attention, and I'll hand it back to Joe.